So let's just start by introducing ourselves, and you can start back as far as you want. It could be nursing school, it could be even beyond that.
Okay. All right. Well, hey, I am Nurse Gwenny. I am a social media educator for critical care nursing, specifically in flight nursing. And my journey in nursing, when I was in high school, I got a full ride to a university that didn't have a nursing program. And I was like, no big deal. I will just do pre med instead. And so I did a year of pre med and loved all of it except chemistry. The chemistry was pretty rough. So I was like, I don't want to do this for like a billion years. So I'm just going to pick something else. And I switched my major to psychology, and it was really pretty easy, those soft sciences. Graduated a semester early and got married pretty young, started having kids. And there's actually nothing you can do with only a bachelor's in psychology. You have to get a master's. So after I got done putting my husband at the time through his master's program, I could never get nursing out of my head. I always think I wish I would have gone to a school with a nursing program. I wish I would have, foregone that full ride and gone to nursing school because that's really what I want to do. And so when I was 28, I went through an accelerated nursing program. So it was a BSN crammed into 15 months. Now we all had bachelor's in something. It didn't matter what. Mine was in psychology, as I just said. But it was a really intense program. So anybody who's been through an accelerated program, like kudos to you because it's nearly unsurvivable. It's essentially the last 3 years of nursing school of a BSN program crammed into those 15 months. So it's pretty intense. But by the time I was done, I was glad that it was over quickly and I was able to get my second career started. And I started out as an ER nurse in East St. Louis, worked there for a year until I moved to Kansas City, put in 3 years at a level one urban safety net hospital. Really earned my trauma stripes there. Took care of a pretty rough population, but had trauma after trauma after trauma. You can blindfold me and I can take care of a trauma patient without thinking about it.
Mhm.
And learned a lot there because it was a teaching hospital. So I'm really thankful for the attending physicians and the residents that I learned so much from my time there. But as working at a place like that does, it really took a toll on me. And I was like, I gotta do something else. I gotta figure out where I'm going to go next. And I'd always dreamed of flying. So I applied for a flight job thinking there's no way they'll hire me, but it'll be good to get some interview experience under my belt and kind of figure out what they're looking for. And they offered me a job. And I was like, are you sure? Like, really? And the learning curve was steep. So I was a good ER nurse. And I thought that would translate into making me a good flight nurse. And I had a good foundation to start from, but there was so much. I had no idea what I didn't know, right? Ignorance really is bliss because I had no idea what I was missing. And so learning to go from an ER nurse to a flight nurse, learning that EMS side of things, holy cow, there was so much I remember getting on one of my first scene flights and I was like, I don't know what to do. I don't know where to go. Like, what am I supposed to do? And my medic partners were really patient with teaching me, like, okay, sometimes you got to crawl inside the car and start working on the patient while the fire department is still extricating them. Or, hey, sometimes we just need to hang back and wait. Or, just learning how to act on a scene because I didn't have that EMS training. So it took me probably a year to even know what the heck I was doing. It probably took me another year to even start feeling somewhat comfortable. And then that was during COVID after my first 2.5 years of flying. And I left flying to go work COVID contracts in the hospital because money is really fun to have.
Mhm.
So I did that for a little over a year and I missed flying so badly. So I went back to it and now I teach full time for a company called Impact EMS. So I travel around the country teaching a course called the Flight Medical Provider. So it teaches nurses and paramedics how to be flight clinicians. I still fly PRN, usually about one shift a week. Sometimes I'll have a busy week where I work 2 or 3 24-hour shifts. And other weeks I might go 2 weeks without flying a shift. And then I still work in the ER also, about 3-ish 12-hour shifts per month. So I'm pretty busy, but it's my policy as the director of education at my full-time gig that all of my instructors are still actively taking care of patients. We're all still flying. We all still work at the bedside because we don't want to teach things that we aren't still doing, right? Because it's super easy. I'm sure everybody remembers having a nursing school instructor that hadn't touched a patient in 10 years. And yes, this is what we learn in the classroom, but patients don't always present like the textbook says they're supposed to. And sometimes we have to get creative and think outside the box, or they might have two pathologies and we have to figure out how to treat both of them at the same time. And so, as an instructor, it's really important to me that I'm still taking care of patients. Plus, bedside nursing, I think, is really fun. I love working in the ER. I love taking care of patients. I love those problem solving puzzles that we encounter when we are working in the emergency department. And flying is just a really cool job. So that's Gwenny in a nutshell.
And just a little bit about me as well. I currently go to nursing school. I'm in my I'm heading into my fourth semester out of five in nursing school, and I
Okay,
recently picked up a gig in the PICU, and so I'm an extern in the PICU. And
excellent.
I actually love the unit. I love all the coworkers, and actually going through clinicals there is what made me want to apply and eventually be on the floor there. And so these last 2 days were my first days essentially on the unit, and everyone was welcoming. I saw some of the nurses that I saw before when I was shadowing them, and I even ran into some of the flight nurses, like the critical care transport team
Yeah,
nurses, and
cool.
I remember them from my time because when I used to do clinicals, which is this spring, I was able to tag along for their ECMO transport simulations, and so
Way cool.
they were running through scenarios like, what happens, how do you like prime this, etc. They had a patient in the ambulance, so we were actually in the ambulance going through scenarios like they coughed up blood and then like the RT was bagging them. And so I thought that was really cool, and it really made me appreciate like the emergency response teams and just how they handle situations with creativity. And
Oh,
also,
so fun.
yeah, and so that just made me like love it even more. But even going back further than that, I always knew like I was drawn to nursing, similar to you.
Mhm.
I got into a program, direct entry program in Fullerton, CSU Fullerton, but it was COVID and we didn't know if our classes were going to be online. So I just forewent that, and I said to myself, if I'm meant to be in nursing, I'll find a way to get into nursing school again. And so I was eventually able to get into a nursing program here in my hometown, which made it awesome because I had my support system with me and everything. And
Mhm.
it was a pretty fun ride from there. I'm really drawn to the ICU, and I feel like it's intense and the learning curve is huge. But if you have people that you work with, coworkers that are really supportive in the environment, that really goes a long way. And so we have two kind of level one trauma centers here. Actually, we have one level one trauma center in our downtown area, but our PICU, I was really drawn to externing in the PICU because of like the culture that they set there for the nurses. Everyone's so helpful. You need help, and 8, 10 people show up in the room. It's amazing, really, and that's what really made me want to get into the path. And I saw these flight nurses be coming on the floor, and just they were super awesome. They had their own way of handling things, which I thought was cool. And yeah, so my question to you would be pretty much, how do you make these life-saving choices when you're miles above ground? Like, what do you prioritize? Obviously, we have the nursing um, guidelines, like the algorithms, the ABCs, but essentially, what does
Mhm.
it come down to?
So my decision making. Um, so I was on a podcast recently with Rapid Response Nurse. I don't know if you watched that episode, but we talked all about the importance of nursing care plans, which I know I'm probably going to make you shudder because you're in nursing school, you're in the thick of it, and you're having to do nursing care plans. And kind of the basis of what I was talking about with her is that yes, in nursing school, I hated doing nursing care plans. I hated, feeling. I was like, this is just busy work. I'm not learning anything from this, and grumbling and complaining about it. When in actuality, it was doing something for me. I just didn't see it until years down the road. When I'm in the helicopter, I don't have to cognitively make a list, prioritize those things, and then check them off one by one. Because I've been doing this so long and I've done it so many times that it all just happens in my brain on its own, and I just do all the things. That doesn't mean that I'm checked out and I'm not thinking about things. It's just like, imagine if you were going to pour yourself a bowl of cereal to have as a snack late at night some night. You don't think, okay, to make a bowl of cereal, I have to grab the box of cereal from the pantry. I have to get the milk from the fridge. I have to get a bowl and a spoon from the cupboard. And the first thing I'm going to do is pour my cereal and then pour milk over it. And then I need to, you don't think about all of those steps. You just know what to do, and you're reaching for the milk, you're going for the pantry, right? And you're watching a movie on your phone the whole time you're doing it because you've done this so many times. You've poured yourself so many bowls of cereal that you just know what to do. And so to be at the flight level, my program requires 5 years experience in the critical care setting, so either ER or ICU. And we really love the ICU nurses, which hurts my feelings a little bit because I come from an ER background, but I absolutely see the value. As someone like you are going to have that PICU experience, that ICU experience, because as an ICU nurse or as an ER nurse, I bring the same skill set, mostly the same skill set to the table as the paramedics do. And what's the value of those ICU nurses that they bring to the table that the medics can't is that familiarity with ICU type things, lots of drips going all at once and how to titrate those. We do a fair bit of that in the ER, but not as much as you guys do in the ICU. Some of those specialty devices, etc. So anyway, you have to have 5 years of that critical care experience before you can even apply to fly at my program. And then we also have all of this advanced training, all of the letters. We have our BLS, our ACLS, we have our PALS, we have NRP, and I'm talking about neonatal resuscitation, not National Registered Paramedic. We have our TNCC, we have PHTLS, we have a lot of letters because it takes a lot of knowledge and skills and experience to be at that level. And so thankfully, I'm not in the helicopter by myself. So the pilot sits up front and he runs the aircraft. And in the back, it's the patient and me, the flight nurse, and my partner, who is the flight paramedic. They are just as experienced, if not more, than I am. We work in tandem as a team. We practice together a lot. We get out mannequins. And just like you were saying, you got to see those simulations happening at the hospital with the critical care transport team. We practice that a lot on our own. We'll practice innovating together. I used to have a partner at my first flight job that we used to be able to RSI, so rapid sequence intubate, someone with hardly any words spoken between us because we had practiced it so many times. We knew who was sitting where, we knew what doses of which drugs we wanted, that our flow was really smooth. And so when I'm taking care of a critical care patient in the sky and I no longer have a doctor to ask for orders, I no longer have, like you were saying, that all of those people that are willing to help in the PICU, I don't have that in helicopter. It's me and my partner. But we can both identify those life threats. We can both identify the most important urgent matters that need to be addressed the most quickly, and we can divide and conquer. If we have a respiratory patient, they can work on, setting up for intubation while I'm grabbing meds and I'm, grabbing some magnesium to give the patient, or he can be putting them on BiPAP if we decide to do that. We can both work in tandem with each other, and it just happens. I don't know how else to explain it other than we're so fluent in this that it just flows really well.
Hmm. And you talked a little bit about it before, but when you were going through your ED, and when you were an ED nurse and you were going through the phases of being an ED nurse, is something in particular that you were paying attention to? What type of knowledge were you acquiring there? Were you looking at like pathophysiology when you were going through there, policies, etc.? What really made you an advanced ER nurse to the point where you felt comfortable taking that next step to becoming the flight nurse?
Yeah, absolutely. That's a great question. You really prepared yourself well for this podcast, by the
Thank
way.
you.
So when I was in nursing school, as I said, it was a very difficult program. I went through an accelerated program and it equated to about 60 hours per week between clinicals and classroom time. It was a lot. And then I had two small children at the time. Now they're teenagers. And so I was raising two kids and I had to work. I couldn't not have a job. And so I was working 2 nights a week as a critical care tech on a tele floor, and I was making $9 an hour. It was absolutely ridiculous. That was the hardest work I've ever done for negligible pay, right? So $9 an hour, 2 nights a week. And so there would be times where I wouldn't sleep for 48 or more hours because I would go to school and clinicals during the day. I would go work at the hospital at night. I would go back to school the next morning. Looking back, I'm like, holy cow, that was outrageously unsafe. But I remember when I graduated thinking, I made it. I can rest now. I can relax. I can just go to work 36 hours a week. This is going to be fantastic. And what I didn't know is that nursing school prepared me to be a different version of a nursing student. You're still a nursing student when you graduate nursing school. Yes, you've graduated. Yes, you've passed your NCLEX. You've got your own nursing license. But especially if you start out in a high acuity place like the emergency department, or like you're going to the PICU. So, time out, let me ask you really quick. Does this mean, since you're doing your externship there, that you'll get a job there when you graduate after
It's
next semester?
So our externship is pretty much an interview of like how we do and then what we pick up. But most likely, people that work there as externs are usually hired after they graduate.
Ah, excellent. I love that for you. So you'll figure this out, and you're going to have a leg up. If you've already done your externship there, you're already going to have the familiarity of just the simple things like, where's the supply closet? Where's the best place to go and cry after a code? Where's the pooping bathroom, right? Because
Mhm.
that's pertinent information that you gotta have. So when you graduate nursing school, you need to be prepared to start learning just as much as you were when you were still in nursing school. So we kind of learn an overview in nursing school, but once you get to the PICU, and when I started in the ER, I had to memorize things like, okay, when I get a chest pain patient, here is my checklist of things that need to happen immediately. Get them on the monitor, put an IV in, draw their labs, get the nitro, give them a sublingual nitro if their blood pressure can handle it. It's hard to do all of these things. So, and studying the pharmacology of medications that I gave every single shift. I'm going to give Zofran every ER shift. I have no doubt about it. I'm going to get it. At the time, it used to be morphine for everybody's pain. We don't give a whole lot of morphine much anymore. We do a fair bit of fentanyl for pain. We'll do a lot of Toradol, try to do NSAIDs. IV Tylenol, top notch. We didn't give that when I first started because it was still under its first 10 years of FDA approval, so it was too expensive. But now there's a generic on the market, and we give it all the time. But the medicines that I give every single shift, studying the pharmacology of those medicines. I would say every nurse, when you figure out what your specialty is going to be, you need to make yourself a list of the top 20 to 30 medications that you're going to give and be super familiar with those. You need to think about the top 5 to 10 pathologies that you're going to see. Study those in depth. If you kept your nursing school books, go back and read more about those, right? Because that textbook that was this thick, how much of that did you retain?
Yeah.
Maybe this much. So go back and read about those pathologies. Seek out other sources of information. What a time to be alive when we have so many free places that we can learn from, whether it's YouTube or Instagram Reels or, podcasts are a great place to learn. And my favorite podcasts that I listen to that pertain to flight medicine is Heavy Lies the Helmet with Mike and Brian Boone. They're fantastic. They're really also just solid dudes. I love it when the people behind a brand are also just as good as the brand itself. So their podcast teaches really great concepts about critical care transport medicine. The Q Word podcast with Nissa Hadaway. She's an ER nurse and also a flight nurse. She's got a great podcast. World's Okayest Medic podcast, all not safe for work. Don't listen to it with your kids in the car because he has really bad language, but you're going to learn a lot from him. So there's great free podcasts that you can learn from, and just listening to those on your way to and from your shift, or if you're going to go on a run, throw a podcast on. My good friend, Dr. Salim Rizai, he's our medical director at Impact EMS, but he runs Rebel EM. It's totally free. I know when I have a clinical question, I'm like, I'm going to go see what Sal has to say about it. So I'll hop on the Rebel EM website and see if he's got an article on it and just learn about it. Another thing that you can do if you're looking up articles, if you read an article, let's say you want to learn more about ARDS. So you look up an article and you think, gosh, I learned some, but I still have questions. Go to the reference list to that first article where you started. That will guide you to other articles, and you can go down a rabbit trail of other articles to listen to, read, or podcasts to listen to that will teach you about that topic. So bringing it back in, I know I really kind of got off track there. Identifying your most common medications and pathologies and study those really well as they pertain to your specialty.
Yeah, and then I was when I was precepting under a person, he was a ECMO specialist on the unit, and he told me the exact same thing. He said, look through the policies of the hospital, and then because that actually makes you seem smart and appear smart. He says the people on the unit tell him he's the smartest person they know, when in reality he just goes through the policies. He read all the policies in detail, and then he also knows the pathophysiology of every like disease pretty much, or not every disease, but like the most common ones on the unit.
Yeah.
And then yeah, and just be more cognizant of that. Watch YouTube videos. He gave me pretty good guides for those. And then the common meds that we give too, because every day or the past 2 days that I've been going to the floor, I've been seeing some commonalities in the medications like propofol, um, dexmedetomidine. Like it's like
Yeah.
all the
Yeah.
medications.
You
Like
can just
oh
say Precedex.
yeah.
Precedex is so much easier to say than dexmedetomidine.
Yeah, because there's different ones too, and you shouldn't get confused with dexamethasone and stuff like that. So
Yes. Yes. Those
um,
are two very different drugs.
yeah,
You're right. That's a
and
good point.
so just going through those phases and learning what medications are common here, the drips, and just how to manage those. You rapid infusions, like how to give the plasma lights like in a bolus. And so my preceptor was able to teach me different techniques of pushing those as well, like the push pull method, like hanging them, etc. So yeah, just like asking those questions, and I'm a hands-on learner, so I asked the nurse at every chance I get if I could do something or if I could watch them and then repeat it. But I feel like that's a really great way to learn. And for me, it was about repetitions and being on the floor on the ICU, because I feel like doing your clinicals there, yes, you have certain days, but if you're putting in those repetitions and you're going there actually as an employee, you get to really pick up on some things that you wouldn't really get to pick up on a snapshot day. So it was just going through that and actually talking to how people do things in a different way, because there might be a person that does everything by the book, but doing it by the book may get you yelled at because you're not doing things efficiently, you're not doing them fast. So you want to do it in a safe manner, but you also want to do it in a manner that is swift. So, and that's where I think the ED nurses really come into play as well, because they know how to do things in such a efficient way, and they make really good flight nurses in that manner as well. And so that combination of ICU nurses and ED nurses is, I feel like that's an excellent combination to have go into flight nursing.
Um, Yes, ER nurses are super resourceful. I kind of make the joke that ER nurses are kind of the raccoons. We're the trash pandas of medicine because we figure stuff out, right? I can make a blow by if we don't have one, because some hospitals don't carry a blow by device anymore for pediatric patients, because peds do not want to keep a non rebreather or a nasal cannula on. But sometimes they need some of that supplementary oxygen. And the ER where I work at now, we don't have blow by, but I can make one out of a styrofoam cup. I'll cut up a nasal cannula and then I'll give it to mom and have mom hold it so it kind of puts a cloud of oxygen under the baby's nose. And then, entertain them. I've got Disney Junior on my phone because my youngest is 6 years old. She watches Bluey on my phone all the time. But I'll tell you what, I use my phone for Disney Plus just as much when I'm in the ER as I do when I'm at home with my daughter, because I'll use it to keep patients entertained so that I can start an IV without them even realizing that I've done it. Or, I can papoose a kid with a draw sheet so that we can give them sutures without them beating the snot out of us. We are really resourceful. And I'll tell you that how to learn how to do that stuff is just to keep your eyes open and your mouth closed, right? As a new grad, I wanted, if when my preceptor would ask me questions to quiz me on things, I wanted to spout off my book knowledge because I'd studied so hard. He would say, okay, what do we do now? And I would tell him what the book told us. And he's like, that's the textbook answer. Like you were just saying, there's a textbook answer and then there's a real life answer. Not that we're violating policy or not that we're going against what we learned in school, but there's a realistic way to apply that knowledge that we learned in nursing school to the situation in front of us. And so I had to learn to just watch others and to pick up on things that they would do. Ask questions constantly. I see you're doing this. Why are you doing that? Hey, you do that differently than this person over here. Can you tell me what's your rationale behind that? I'm a decade into this nursing thing. I've been flying for 6 years now. And I still, after every single transport, I will ask someone, whether it's my partner or the nurse at the bedside where I hand the patient over, or if there's, an attending at the bedside, I'll ask him, hey, what could I do different or better next time? And sometimes they'll say, nothing, it was great, thank you, and we move on about our way. And sometimes it's just a little maybe operations hint. Like I asked one of my partners recently, and he's only been flying for like a year. He's been a medic for maybe 5 years. And I asked him, I said, what's something I could do different or better next time? And he chuckled and he looked at me and he said, why are you asking me? You have so much more experience than me. And I said, yeah, but there's things that I don't. Like, I can still learn from you, even though I'm older and I have more experience. You can still teach me something. And I said, I need you to think of one way that you could help me be a better partner to you. And he started thinking and he said, can you stop carrying everything by yourself? Can you let me help you? Because I look like an asshole if the female flight nurse who's a foot shorter than me is carrying all the bags and I'm just over here carrying nothing. I said, yes, I can do that for you. I can let a man carry my bags for me. So it had nothing to do with patient care, but it helped us to improve our team dynamic. So just being willing to learn, keeping our eyes and ears open, and just being coachable. I will tell you, I get so many people that will DM me and will say, hey, I've got a flight interview. Tell me what I should be studying. And I'll say, it's not the clinical knowledge, because any company or any hospital can teach you clinical knowledge, but they can't make you a better human being. They can't make you a better teammate. That has to come from you. You've got to have that intrinsic uh, good humanity about you, that you're kind to patients, that you're a good teammate to your coworkers, that you've got integrity, that you're going to do the right thing even when no one is watching, that you're going to go the extra mile to, whether it's something as silly as massaging your patient's feet. If you've got an order for Q2-hour pain medicine and we're at the 90-minute mark and you can't give another dose yet and they're super uncomfortable, is there some non-pharmacologic things? Like, is it comfortable? Does it feel, I have personal space issues. I don't like to touch other people, but if it's going to help my patient, yeah, I'll massage their feet, even if feet are pretty gross. Or, helping them to get in a comfortable position, getting them a fresh ice pack, just doing the right thing for our patients. That's what a hiring manager is looking for, not
Yeah.
so much the smartest person they've ever met.
Yeah, and that's very important, and especially in like a setting where I'm at the PICU, it's not essentially the patient sometimes, it's the patient's parents that are more hands-on, and they're pretty much frustrated. I mean, they're at their most vulnerable point, and their
Yeah.
child is there at the hospital, and they can't do anything about it. They feel like they're out of control, and it's just, getting them involved in the care too, even if it's something really simple like how having them like hold still, at least they have that feeling of being in control, being able to do something for the patient. uh, we had a patient where the mother or the father, I forgot who it was, but they would keep a book of every nurse that would come in the room, and then they would write their name down and pretty much write everything that they would do on the notebook. But now this seems like something that would like piss off a nurse, like, oh, why are they doing this? Why are they writing everything I do down? Like, what are they plotting? But come to find out later, they were writing the names down because they were praying for the nurses. So you don't
Oh,
really necessarily realize what the patient is doing. You don't understand their side of things. So it's just better to keep an open mind in that area. I know in the critical care settings, you get hung up on lines, drips, you get hung up on procedures, but there's also that aspect of, like you said, being a good human that comes into play in the ICU as well. um but how do you, so you're working in such a high stress environment, how do you keep your cool, how do you cool down, how do you reset yourself, like what is your process for that?
yeah. So that took a lot of intentional effort. So I'm a little bit of a high strung person. I've been told that a lot, or sometimes people will say, you're so intense. And like, I know what's going on inside my head. I can function really quickly. And I used to have a little bit of a chaotic vibe about me. I could do a lot of things, but I might make a big mess while I'm doing it, or I'm kind of clumsy. If I trip over a mayo stand and it sounds like a bomb went off, I don't think you guys have those in the unit. You guys have nice, like, plastic tables that don't make as much noise. But in the ER, we have these Mayo stands that are metal. And I swear, even if you just make eye contact with it, this thing is so loud. but I'm clumsy and I would, fall a lot and drop some things. And it was actually a guy in registration that said to me once, he said, Gwenny, you're really good, but you're really clumsy. And it's not because you're like, ha, you're just clumsy. It's because you move too fast. He said, slow is smooth and smooth is fast. And so I remember back in 2019, I always set a personal goal at the beginning of the year. And my personal goal for that year was to kind of bring my vibe down, to have a calmer vibe around me. And so I still know I can still function just as quickly inside my head. I can still identify all the things I need to do, but I want to find the most efficient and the least chaotic way to achieve those goals. And so sometimes, especially when I'm teaching, like, have you ever gotten a report from an ER nurse and she's on 4 sentences in and you're still taking notes from the first few words? That used to really irritate me as an ER nurse. And also when I'm teaching, I speak really quickly. And so I've learned that I have to slow my cadence down, whether I'm teaching in the classroom, because there's like smoke coming from my students' pencils. They're writing so fast. And so I've got to slow down and give them time to receive everything that's coming out of me at 1,000 miles an hour. Or when I call report, I might have to, all right, here's what's going on with the patient. Instead of saying, came in as post-cardiac arrest, we've got ROSC, I've got an art line in the left radial artery, I've got levofed going at 30 mics a minute, blah, 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 blah. And the ICU nurse is like, whoa, I have no idea what you just said. So slowing it down, less chaos about me, and it took a lot of intentional effort. Now, to personally manage the stress, I had a couple of rough years. I don't want to go into kind of my whole story, but when I first started flying, I let some of the cases and the stress of the job really get to me, and it really kind of wrecked me. And I have since learned it's not wait until you are in a kind of a status of a crisis of whether that's grief or burnout or overwhelm. It's really easy to get overwhelmed as a new grad. Don't wait until you're in the thick of it to try to do something about it. You really have to build that resilience ahead of time so that you're not trying to dip out of an empty bucket. So making sure that your identity is in who you are as a human and not what your job is. People will say to me sometimes, you're so passionate about nursing education. I'm like, no, I'm not. I'm not passionate about this. I'm passionate about the people that I love the most, my significant other, my 3 kids. I'm passionate about traveling the world and enjoying my little piece of the world that I have here on my 10 acres. Nursing is a really cool job, and I think I'm good at what I do, but it's not my passion. So my identity is no longer in who I am as a flight nurse. It's who I am as a wife and a mom to 3 and a friend and a sister and a daughter. And when we keep those things in the front of our mind, then when we have a bad day at work, it's not a bad day of the biggest part of our lives. It's a bad day at a job that we go to 3 days a week. And it's easier to process kind of the traumas. I'm not saying that traumas never get to me anymore. I had a case that kind of messed with me maybe 2 or 3 months ago where I delivered a baby on the way to the hospital, and the mom had been beat to an absolute pulp by her boyfriend. It kind of resurfaced some old trauma in my life when I was in an abusive marriage. And because I had that resilience and because I have that support structure to turn to those I love and say, whoa, this one reminded me of a really dark time in my life. This one hurt. Those people surrounded me and loved me and got me through that. And so it was just a bad couple of days where I was thinking about that case instead of it spiraling me into a bad chapter of life. So build that resilience ahead of time, have that support structure, go to therapy preemptively. Don't wait until you're in the thick of it. And that's my best advice to how to handle the stress of this job.
Yeah, and like some of the points he mentioned, our clinical educator was like, "Oh, don't wait until something happens. Make sure you have someone to talk to. If you need therapy, make sure you have that in order." And pretty much, it just helps you with the longevity of your career because if this is something that you really like, it's not a matter of when it's not a matter of if, it's a matter of when it's going
Yep.
to happen because
Yep.
they said it does happen to everyone, and you just have to have a system of dealing with it, have to have a someone to talk to, like your support system, your family. And if you don't have any family, make sure you have friends that love you, and support you with whatever you're going through. But yeah, and so moving forward, with that in mind, what are like some major injuries that you've dealt with in the sky, like off the bat? Like, was there something like a critical case in the sky, and how did you manage that?
You name it, I've seen it. From traumatic amputations, motorcycle crashes. I kind of joke that I would be out of a job if it weren't for motorcycles, four wheelers, and alcohol, because I see some really gruesome injuries because of those three things. Especially right now in the summertime, we kind of call it trauma season, from
Yeah.
Memorial Day to Labor Day. That's kind of the bulk of our trauma season, where we see the most motorcycle accidents, four wheeler accidents, drownings, things like that. Each case is managed with the same ABCs. Well, really March instead of ABCs, where you're looking at massive hemorrhage, airway, respirations, their circulatory, expose them and watch the environment that you're exposing them to, right? We know that the hypothermia is part of that trauma triad of death. So just managing every patient in regard to their ABCs, controlling their bleeding, manage their airway, breathe for them if they need it, and keep their circulatory system going, whether that means give blood products or give different drugs to help them maintain their own circulatory system. So even though there are hundreds of pathologies, like the protocols, all of my flight team, we all have our protocols memorized. I still study my protocols. I pick out one protocol every shift and I just read over it, and it's a protocol that I have memorized, but sometimes I read through it and I'll think about it differently, or I'll think back to the last case I had like that and just try to learn something in that moment, or talk about it with my partner and they can say, hey, one time I had this really cool case. So we have hundreds of protocols memorized. There are hundreds of pathologies that we see, but really we treat them all the same. Is their ABCs: managing their airway, their breathing, their circulation, take care of their pain, do what we can to alleviate the patient's suffering and get them to the definitive care that they need, whether that's a burn center, a trauma center, an ECMO center.
Yeah, and like that diversion that you're mentioning is very frequent at our hospital as well, because it's a really huge specialized trauma hospital for children and specialty hospital for children. We sometimes also get people from like let's say we get adult cases. We have people coming in through the ED, and we can't necessarily turn them away. So they do their best to stabilize them and
Mm-hmm.
turn them to, or if they're doing good, and then they direct them to our nearest adult hospital. And that's something with our community here as well, the hospital community. There was another adult hospital that closed down, so they've been getting a lot of those cases there for the adult population. And then they're like, whoa, what do we do? Like, this is an adult patient, and it's normal to freak out in emergency situations. Like, it happens to the most advanced and most knowledgeable people. And we had a case recently where there was an 80-year-old patient that came in, and they were trying to get access. They were like, oh, I got it this time, got it this time. Or I don't believe it was the adult patient, it was some other patient, but it was a hard access for them. And they were trying to get the IV in through the vein right here, the
Mm-hmm.
jugular vein, and they
Uh-huh.
pretty much couldn't, and they were bleeding out from there. It was like, oh yeah, at least we have access. But the I believe the paramedic or someone else offered them to try the IO, which is a new piece of technology. I didn't even know that was a thing. The IO access, intraosseous. So that leads me into my next question. Are there any new technologies that you're looking at in terms of taking care of patients, like that may help you in the future as well?
We've been using IO. Gosh, I think I've been doing IOs ever since I started flying. We had them in the ER, but the
Hmm.
nurses weren't allowed to do them. Only our physicians were when I was in the hospital. But we do them all the time in flight. So I've been doing that for 6 years since I was flying. It used to, before we had the IO guns, the easy IO, we used to do them by hand. And sometimes I still
Mm.
do them by hand on pediatric patients if we can't get access anywhere else. I will put it in by hand because the gun is too much for those tiny pediatric patients. But I would say, our ventilators continue to get more sophisticated in the transport environment. Kind of the sparkly ventilator that everybody wants in the pre-hospital environment is the Hamilton T1, and that's what my program flies with. It's a phenomenal piece of technology that's very capable. of doing some pretty complex ventilatory strategies. Some places are getting POCUS, which is point of care ultrasound. My program does not do POCUS, but that's kind of one of the technologies that's out there. My service just switched to using Pulsera, which is a way to notify the local hospital that we're coming in, so we don't have to call radio report anymore. It's just an app on our phones that we fill out a quick sheet and just shoot it to the ER, and then they know we're coming, and we don't have to waste anybody's time calling radio report and tying up the kind of airspace in the area.
Perfect, awesome. And then I know we talked a lot about flight nursing, etc., but could you just summarize the path that someone watching this, like, because I'm the president of a student body at our nursing program, so if we could get this information to anyone who may be interested in flight nursing or want to pursue this path, do you have a general advice for them?
Yeah, absolutely. So, as I was saying earlier, be coachable, learn all of the opportunities that you can. It is up to you. If you want to be a flight nurse, don't wait on someone to hand it to you. You got to go out there and chase it. So, go get your EMT after you get settled in and through your orientation, and wait till you get comfortable in your ICU or your ER job. Go get your EMT and get some ride time on an ambulance. Because I was saying, when I was a new flight nurse and I didn't know my rear end from a hole in the ground on a scene because I'd never been exposed to that. No one had ever taught me that. And it would have been helpful had I gone to get my EMT and just learned what it's like to be on a scene, right? So get as much experience as you can, learn as often as you can, and sit for your advanced certification. So to fly, you have to have your CFRN, your certified flight nurse. Most companies will give you 1 to 2 years after hire to get that, but if you can earn that before you even apply for your job, you will be even marketable as a very strong candidate. So be coachable, be a good teammate, learn from others. If you are work near a flight service who lets you do fly-alongs, go for a fly-along for a day and see what it's like, because it might turn out that you get really airsick and it's just not going to be for you, right? You might
Yeah.
learn that you don't like the smell of Jet A, or you can't handle the sound of the rotors, and that's okay. It's not for everyone. But yeah, just get out and learn as much as you can. So the path is a minimum of 3 to 5 years of that critical care experience. So ER or ICU. I would recommend also getting a PRN job in the opposite one. So you're going to be working in the PICU. So if you wanted to fly, get a PRN job in the ER and just work down there once a month and just get some of that experience. So make yourself a very well-rounded candidate. Also keep yourself physically fit because it is hard work. It is hard on your body to be a flight nurse.
Perfect. And I believe that that's all for the podcast. Thank you so much for joining in. And if anybody has any questions or if anybody wants to learn something new from your Instagram Reels, I will link your information in the description and you guys can go check them out from there. But yeah, thank you. Is there anything else you would like to add?
Oh, just thank you so much for your time. You really are just filling my heart with joy, and I am so happy to see someone as eager and smart and bright as you in the next generation of nurses. I do also have 2 books that are available on Amazon. So one of them is a test prep book if you want to be a flight nurse or a flight paramedic. It is called But Why? Going beyond the what so you can understand the why of critical care transport. If you just go to Amazon and type in "but why Gwenny Lawson," it'll be the first thing that pops up. But it's over 300 practice test questions with the answers and rationale. So it not only gets you ready for the exam, but it gets you the knowledge that you need to actually take care of those patients. So yes, it's a textbook, but it has some funny stuff in there. At least I think my jokes are funny. I have a few 4-letter words. It's different than any textbook you'll ever read. And then I have another smaller book. It's called 50 Reminders, Affirmations, and Validations for Nurses in the form of Bible verses, quotes, and a few swears. So I just took 50 different quotes and then put it on some really pretty paper because we see a lot of unpretty things in our job, whether it's a code brown or a pediatric cardiac arrest or blood and guts. Like we see a lot of yucky sights. And sometimes we just need something pretty and to make our heart feel good. So it's 50 quotes. And then on the back of each page, I just kind of applied those concepts to nursing. And the book is not designed for you to read it and then put it on a shelf. It's designed for you to rip it apart. I want you to tear pages out and share it with your coworkers. If you see somebody else having a bad day, Find a quote that you think will help them, write a little note to them in the margin, rip it out, and leave it on their computer station at the nurse's station. So both of those are available on Amazon, and then I've got all of my free content on TikTok and Instagram. I love
Perfect.
interacting with people, with students like you. So send me a DM. I'm happy to help people.
Perfect, and I'll link all those books in the description. I believe that's the best way to write a book and have it be relatable to everyone. So yeah,
Yeah.